Okay, I guess we'll get started. Thanks everyone for joining, and thanks Rutan and Co at Africa Quantitative Sciences for inviting us to give this webinar. We're really excited to be here. Um, could I just confirm from some of the audience so you guys can all hear us before I get started? Okay, great. Why don't I just introduce myself? My name's Jay. I'm based out of Vancouver, British Columbia, Canada. I run a small consulting company that specializes in causal inference and other types of innovative methodological research for clinical research and other types of like health and medical related research as well. And I'm a part-time faculty member at McMaster University, where the evidence-based medicine was originated from. And I'm delighted to be joined by my colleague Quang, who I'll ask to introduce himself next.
Thank you, Jay. Hello, my name is Quang. I'm a statistician at my organization, Core Clinical Sciences. My training is chiefly in statistics, and I have received my master's degree from St. Fraser University in Vancouver, Canada. At Core Clinical Sciences, I have been working on projects mainly in causal inference.
Okay. Yeah, so let's just get started. Um, can you guys all see the screen okay? Okay, great. So we'll be talking about um, how we can potentially leverage transportability and generalizability analysis to improve global health decision making. So just to note, like we'll just go over this in detail. Hey, Rutan, how are you? Um, and this is just, us. You can reach out to us anytime. I think I provided my email at the end. But here are sort of the intended learning objectives for today's session. So we'll review the key concepts of and terminologies around transportability and generalizability analysis and how they relate to and help what we call target validity. I'll explain these terminologies shortly here. And Quang will go over high-level overview of general practical steps that we take when we are conducting these types of analysis. And we will also provide the current landscapes to highlight the lack of applications and in specifically in global health. And hopefully we will have an interactive discussions on how we can sort of better leverage transportive analysis and generalizability analysis moving forward for global health decision making. Um, Here are our intended takeaways from our presentation. Ensuring high internal validity, so controlling for different confounders, especially when we are interested or running clinical trials or other types of studies that are aimed to determine how well a certain treatment works compares to the local standard care or other types like a placebo. Um, and we will just highlight that randomization is a very powerful tool that can ensure high internal validity, and we should definitely do more of these high quality RCTs in global health. But we just need to acknowledge the fact that because most of the RCTs are conducted outside of Sub-Saharan Africa and other LMICs, that local decision makers are do face important challenges, considering whether to adopt a certain medical intervention or not in their local country, because the largely the trial evidence and other types of medical research evidence comes outside of Sub-Saharan Africa. And we'll be highlighting that considering the local context is very critical. And instead of just qualitatively questioning the external validity, so for example, how well will the intervention work in the local setting, we can consider adopting transportability and generalizability analysis to quantitatively assess how applicable the findings are to the local setting. Um, so I'll just start us off. And I'll just say that this, you guys may have seen this sort of hierarchy of evidence where we usually put in terms of study design, randomized clinical trial as a top of the evidence. So, for example, the WHO often formulate their clinical guidelines based on meta-analysis of published RCTs for RCTs. And this is in, and let me explain why this is the case. And so why do we use randomized clinical trials as the main source of evidence? It's because they can control for confounders very effectively. So, and they, in turn, they can ensure very high internal validity. So as you can sort of see on the schema on the right, the process of randomization involves randomly assigning participants to in this setting it's at an equal allocation to where half of the patients would get randomly assigned to the new drug, and the other half maybe get assigned to the control group that may consist of an established active care or other types, or it could be a placebo control as well. Because we do this, we randomly assign participant into the study arms in comparison. This can help minimize selection bias, and in turn, they create groups or study arms that are comparable in prognostic factors. And these prognostic factors can be comparable in terms of both that what can be measured and what's not measured. And in turn, what we see at the end of the trial, and when we compare the sort of the clinical outcomes between the treatment and the control arm, we can attribute that difference as a causal effect of the treatment on the clinical outcome that we're studying. So this is all really great, and this is all very theoretical benefits of randomization, and explains why randomized clinical trials are used as sort of the core evidence base for decision making in global health. But what are the challenges with that? So in 2021, we published a paper in the Lancet Global Health and we looked at how many clinical trials are being conducted in sub-Saharan Africa. So you can see on the map that you see here, you can sort of see that in US, where the majority of the clinical trials occur, you see that highlighted in red. In sub-Saharan Africa, there aren't too many clinical trials being conducted. In fact, it only represented roughly around 2% of the global trials that were conducted. And if we go outside of country like South Africa, sort of these 2% gets distributed quite narrowly across different regions. And unfortunately, this includes Rwanda based on the data that we've looked at in 2021. And because most clinical trials are conducted in high-income countries like US, the extending the findings from the original study to the local setting can be challenging. For example, there are important differences in population characteristics in terms of demographics like age and existence of other comorbidities that may influence and affect the treatment effects if it gets implemented in the local setting. Due to these sort of large demographic differences, it's really hard to find, without using any quantitative methods, to see how well the findings are applicable and are potentially beneficial to the local setting. So in turn, what we advocate for is just to highlight that while internal validity and control for the confounders has received the most of the focus and discussion, we need to consider the local context and consider how applicable the findings are to the local population. And this is what we call external validity, and this is equally important. And we're not saying that ignore internal validity, because that we need to ensure that ensure high internal validity to ensure that the comparative effectiveness, the findings that we find are valid. But equally, we should think of external validity jointly at the same time. And this is where I like to introduce the terminology or concept called target validity, where we can jointly consider internal and external validity together. And if we just look at this figure on the right here, What we see on the y-axis or the vertical axis is what we could sort of the decision breakdown of where we have high internally on the top and low internally at the bottom. Because at the bottom left there, or top left there, even though you have high internal validity and you have adequately control for the confounders, because perhaps this may have limited relevance to the target population, and we would consider to have lower target validity. And if we see on the x-axis or the horizontal axis, you can sort of see that even when we have high external validity, because maybe the study was conducted in a local setting, if we don't have adequate internal validity, this will still have results in a lower target validity. And the situation we want to be in is at the top right corner, where we can ensure both high internal and external validity. And so this terminology of target validity is really crucial for local decision making, because we can now think of jointly the internal and external validity together. And I just won't go into this the target bias and internal bias and etc. But I think this will become more apparent as we go through more examples. I'm going to pass the presentation to Quang, who's going to give us a quick introduction to causal inference to establish common terminologies.
Thank you, Jay. So I'm going to give a brief introduction of causal inference now. This may come off as being a little bit out of left field, but please be assured that this provides us the necessary tools to tackle target validity issues. Next slide, please. So causal inference is the field of statistics which is interested in the study of causal relationships between variables. Typically in statistics, we are happy to study the associations between variables or merely their correlation. However, in causal inference, we're interested in how much changing one variable leads to a change in another. Like there's a direction of cause that we are interested in. With this interest in mind, causal inference lets us talk about the issues which harms target validity and how to account for them effectively. Next slide, please. So to help us to facilitate discussion in causal inference, we need a graphical tool called a directed acyclic graphs, or DAG for short. We also call them DAGs for short. These are tools which summarize our assumptions between the causal relationships between the variables. So you can see the graph on the right is an example of a DAG, and it can be pretty intuitive to read off them. So the oval shapes with the names are called nodes. They are meant to represent variables that we are interested in. Then the arrows, also called the edges, represent direct causal relationships between the nodes. For example, at the bottom on the left, you might notice that there is a node from treatment to response. This means that there is a direct causal relationship from treatment to response, meaning that changing the treatment will directly change the response. Similarly, at the top, a little bit towards to the left, you can see that there is an arrow from unmeasured to measured. These just represent variables that are unmeasured and measured respectively. So the arrow from unmeasured to measured means that changing unmeasured will change measured directly. Next slide, please. So with those components of DAGs already explained, what really matters is how they form together in a DAG. So if you just follow the nodes and arrows in the DAG, ignoring their direction, you form a path. In the DAG on the right, two examples of paths are treatment to response, and that's the first path. And the second path is treatment to measured to unmeasured, then to response. sorry, as you can see, we ignored that fact that the first two arrows point backwards, and we still count that as a path. So in a DAG, a path can be open or blocked, and there are formal rules to determine whether a path is open or blocked. We can discuss this further if you're interested after the presentation. But generally, variables at both ends of an open path are associated due to the causal relationships in the path. In other words, if a DAG is true and you collect data for all variables in the DAG in the real world, then you'll find that if you can find an open path, then variables at the ends of that path will be correlated. So variables are associated when they're at both ends of an open path, right? However, the variables may or may not have a causal role in a path. Let me explain this a little bit further. So in the path treatment to response, it's an open path, so they are correlated. And they are correlated in this path precisely because changing treatment changes the response. So treatment has a causal role in this path. However, in the other path, treatment to measured to unmeasured to response, this is also an open path. And so treatment and response are also correlated to this path, but they are not in this path particularly, they are not correlated because treatment causes response. It's because the variable unmeasured affects treatment and response directly. Because changing unmeasured changes treatment and response at the same time, that induces the correlation in this path. So in this path, the treatment does not have a causal role. Another term that you might be more familiar with is the concept of a backdoor path. That's the more commonly used term when discussing DAGs. Um, when discussing DAGs in a technical sense, but I opted to use the term causal role to make it what it means more explicit. Next slide, please. So that gives us the language to talk about confounding. So when we are investigating two variables, A and B, and we are interested in how much changing A changes B, confounding refers to the situation when the association between A and B reflects causal relationships in reflects causal relationships in which A does not have a causal role. To give a more concrete example, take a look at a more real-life example DAG on the right. So there are three nodes: number of firefighters, monetary damages, and size of fire. There's an arrow from number of firefighters to monetary damages, and two arrows from size of fire to number of firefighters and monetary damages, respectively. So let's look at the arrow at the bottom. So it's pretty intuitive that if you send more firefighters to a fire, then you would be able to contain the fire more effectively, thus limiting the amount of damage done. However, when the fire is large, fire departments tend to send more firefighters, and the damage will be higher regardless due to the size of the fire. So when you collect data on these three variables in the real world, it is entirely possible that you find that the damage is higher when you send more firefighters because they tend to be sent to be larger. They tend to be sent to larger fires, which have higher damages. So in this case, the association between the number of firefighters and monetary damages is distorted due to the size of the fire. And this is a prime example of confounding. Something similar may happen in randomized clinical trials too. In this case, for RCTs, number of firefighters is analogous to treatment. Monetary damages is analogous to your preferred clinical outcome. And size of fire may refer to other characteristics such as other clinical characteristics, demographic characteristics, and so on. As you can see, confounding distorts the actual causal relationship between variables and leads to poor internal validity. So what can we do? Next slide, please. So the causal inference framework provides methods to adjust for confounding. So we are able to take into account the variables that may cause confounding and receive estimates that reflect the causal effects of treatment more accurately. So some examples of causal inference methods are propensity score matching and propensity score weighting. The propensity score refers to the probability that an observation is assigned to the treatment group in an RCT or an observational study mostly. I should rephrase that. The propensity score refers to the probability that an observation receives the treatment group. Propensity score matching proceeds by matching observations between the treatment and the control group, such that the propensity scores between matched observations are close to each other. The effect of this is that it will balance out the distribution of the variables between the treatment and control group that may cause confounding. Propensity score weighting alternatively constructs weights based on these propensity scores and then weighs the observations, which will have the same statistical effect. So confounding adjustment methods like these address the internal validity component of target validity. Next slide, please. So we're in a great place to start talking about transportability and generalizability now that we know a little bit about causal inference. Next slide, please. So while we were talking about how causal inference methods deal with internal validity earlier, transportability and generalizability analysis are still causal inference methods, but this time they deal with the external validity component of target validity. Transportability and generalizability analyses are interested in whether effect estimates from a particular study can be applied to a target population of interest. So whether effect estimates derived from a study can accurately estimate the same effect population-wide in a different population from the study sample. So the differences between these two terms is that in generalizability, the target population is a superpopulation of the study sample. So the study sample is drawn from the source population. In transportability analysis, the target population is distinct from the population from which the study is drawn from. So generalizability analysis is essentially a special case of transportability analysis, and the difference is only in the nature of the target population. So in these methods, in transportability and generalizability analyses, the focus is less on variables that cause confounding, but more on variables which we call effect modifiers, which change the effect of a certain treatment on the response. Next slide, please. Yes, transportability analyses single out effect modifiers as the reason why treatment effects may be different between different populations. So in causal inference, we aim to balance variables which cause confounding between treatment and control arms. In contrast, transportability and generalizability analyses adjust for different effect modifiers between the study and target sample to assess the external validity of the study. We may or may not to do both. We may or may not need to do both at the same time, depending on the design of the source study. Next slide, please. So transportability analysis adjusts for effect modifiers in a similar way as causal inference methods. So earlier I introduced the concept of propensity score matching and weighting. Propensity score is the probability of receiving treatment, receiving the treatment group. Now we can calculate the propensity of study participation instead. Or more specifically, the probability of being in the study sample. And from here, from these probabilities, we can construct weights via a method called inverse odds of participation weighting, which is then used to weigh the original study data. Next slide, please. So the statistical effect of these weights is that they try to make the the distribution of effect modifiers from in the source study more similar to the distribution of effect modifiers in the target study. This can be seen in figure A. So on the left, it's a density plot of the effect modifier in the source and target studies. These roughly outline the shape of the distribution of the effect modifiers in both studies. So as you can see, they are both unimodal, but their mode are at different places. Then after constructing the IOPW weights, the inverse odds of participation weights, we move to the plot on the right, which shows the same density plots, but the difference is now that the observations in the source study are weighted. After weighting, the distribution of effect modifiers between the source study and the target study are now more similar. So hopefully with this weighting, we are able to calculate effect estimates that are less biased for the effect in the target population. And this is illustrated in figure B. So the purple dot represents the true effect in the target population, and the orange dot shows the effect estimate that we would get if we only had the original source study data. As you can see, they are pretty far apart, so the original study has poor external validity. If we apply transport, when we apply transportability analysis methods, we are hoping that we get the estimate, the green estimate at the bottom on the right, which is closer to the true effect represented by the purple dot. Next slide, please. In terms of actually performing transportability analysis, we can proceed as follows. First, we must determine a research question of interest. In particular, you must determine what intervention or treatment you're interested in, what you're comparing it against, and what's your outcome of interest, which can be very flexible. And then you must identify the target population of interest. Afterwards, you may engage with stakeholders and experts to construct direct acyclic graphs and apply causal reasoning to these DAGs in order to identify confounders and relevant confounders and effect modifiers, so that we can apply the transportability analysis methods later. After this, we will identify potential data sources for the source sample and the target sample. I will elaborate these terms a little bit later. And once we've identified the data sources, we will proceed to collect the data sources and then clean them for analysis, and then finally perform the analysis and present our results. So to make these steps more explicit, we will now do a hypothetical case study. Next slide, please. Yes, we will do a hypothetical case study. So the first step is to determine the research question. So let's determine a research question now. We will be interested in the effects of an antihypertensive medication, which we will call treatment, on systolic blood pressure. And we're going to compare this to standard of care. So the outcome of interest is systolic blood pressure. Suppose also that we have an observational study conducted in the US, which collected data on the treatment each patient receives and their blood pressure, as well as some other characteristics. So now and then we will identify our target population as the local population in Rwanda. So that completes our research question. We will estimate the effect of treatment on systolic blood pressure for the local population in Rwanda. Next slide, please. Then step 2 is to construct a DAG based on stakeholder engagement and expert elicitation. So suppose that this step has been done and we receive the DAG on the right. Do note that this step can be quite complicated and the DAG can be quite large, but we present this DAG for simplicity. So there are rules to determine which covariates we need to control for to adjust for confounding and effect modifiers to adjust for between the study and target samples. We can also discuss this a little bit later if you are interested. But for now, we can see from this DAG is that to control for confounding, we need to control for the covariates sex, percent body fat, and stress level. And the effect modifiers that we should adjust for are stress level and aspirin usage. Note that stress level is both a covariate and an effect modifier. In particular, any variable except for treatment and response can be both a covariate and an effect modifier. Next slide, please. So here's a summary of the relevant variables. So our outcome is systolic blood pressure, which is a continuous variable. Then sex is a covariate, it is binary. Percentage body fat is also covariate, which is continuous. Stress level is a covariate and an effect modifier, and it is binary, representing higher low levels of stress. And finally, aspirin use is an effect modifier, and it is a binary variable. So to account for confounding, we will adjust for the covariates using inverse probability of treatment weighting, which is a very standard causal inference method. And we will account for the difference in distribution of effect modifiers between the source study and the target study using inverse odds of participation weighting as we have alluded to before. Next slide, please. So now we are ready to collect the data and we need two data sets. So the first data set is called the source data set, which is data from the study whose effect estimates we wish to transport or generalize. So crucially, the source data set needs to contain information on the treatment and the outcome, as well as the covariates and effect modifiers. The second data set that we need is the target data set, which is data collected from the target population with relevant information on the covariates and effect modifiers. In particular, this has to be local data with patient-level effect modifiers, and it is important that this data reflects the local population that we wish to generalize the findings of the source data to. Next slide, please. So once we have obtained these two data sets, we can proceed with the analysis in a number of ways. The naive analysis is just to take the mean difference in blood pressure in the treatment control groups. But as we have discussed it before, this effect estimate will have poor internal validity due to the confounding, as the original study is an observational study, and it will also have poor external validity because it is conducted in the US, whereas we are interested in the effect estimates in Rwanda. The second way we can go about the analysis is to do propensity score weighting, which is to construct weights based on propensity scores in terms of covariates in the source data. This will improve the internal validity of the effect estimate, but it will still have poor external validity. Finally, for inverse odds of participation weighting, we combine the above weights with additional weights constructed based on the probability of study participation in terms of effect modifiers in the source and target data. This will improve both the internal and external validity of the estimate, and thus it will have the best target validity of the estimates. Next slide, please. So the Now I'm showing you the effects of the propensity score weighting within the source data. So on the left, you can see density plots representing the distribution of the covariate percent body fat between the control and the treatment group. As you can see, they are quite different. Then we construct the propensity score weights and apply it to all observations in the source data. And we move on to the density plots on the right, which shows the distribution of percent body fat in the control and treatment groups after weighting. As you can see, the similarity between both distributions have somewhat improved and thus reduced some concerns about confounding. Next slide, please. Now we're showing you the analogous behavior for the inverse odds of participation weighting. The bar charts on the left shows the proportion of patients in the source and target samples with high stress. In the source, it's just about 40%, whereas in the target, it's more than 60%. So they are quite different. Then we construct the inverse auto participation weights and then apply it to the source sample. And after applying these weights, we can see that the proportion of observations with high stress are now more equalized between the two samples. And thus, we hope this will let us estimate the effect in the Rwandan population more with less bias. Next slide, please. Here's an example of what you might expect in the results. So the naive estimate will show that the medication, the treatment, will have a pretty strong effect on reducing the systolic blood pressure of patients. But as we have discussed before, this strong relationship might have been distorted due to confounding covariates in the original study. We deal with this by applying propensity score weighting, which attenuates the effect a little bit and improves the internal validity of the estimate. But this still has poor external validity because we haven't accounted for effect modifiers yet. And then at the top, once we've accounted for effect modifiers, the effect now becomes not significant. So this is a pattern of the analysis results that you might see for real RCT data. And that concludes our case study, and I'm going to pass the presentation back to Jay.
Okay, thanks, Quang. Now I'm just going to take a perhaps step back, gone over sort of technical steps of how you would conduct transportability analysis using the inverse odds of IOPW methods. But I just want to take a step back and talk about sort of the big picture. And I'm going to talk about the current landscape of where and how these analyses have been applied thus far. So, we recently finished a comprehensive literature review to identify essentially any studies where they have applied these methods on real data sets. And this is currently submitted for peer review at this time. But essentially, what we aim to do to figure out where these analyses are being applied and what types of different methods are being used. There are other forms of methods, transportive analysis method, than the one that we went over just now. And we also wanted to see what are the use cases and what potentially, like where could we take these causal inference applications moving forward. So this is just showing the results of our landscape analysis, or landscape assessment. In total, we found 58 different publications that consisted of 70 unique pairs of source and target data. Because some of the publications had more than one analysis, there were in total 86 different applications of transportability and generalizability analysis. Uh, so we did note the distinction, slight distinction between transportability and generalizability analysis, and we so that roughly the split is 55 to 45%, and they've been mostly applied in the areas of oncology, cardiovascular disease, and mental health. And if we take a look at the different sort of study design types or of both the source and target data. Not surprisingly, the majority of the source data and the applications consists of individually randomized clinical trials. And this is where you randomly assign individual participants to a treatment or a control of interest. This is contrast to cluster randomized trials where you randomly assign different clusters like hospital units or other sort of geographic sectors to an intervention or not. That's commonly used in global health. And if we take a look at the target data, not surprisingly, the majority of the target data consists of an observational data set, like population health surveys and so forth. And the applications that we saw the most frequently was where the findings from an individually randomized clinical trial was transported to an observational setting. And also, there were notably some other interesting applications, such as where they transported the findings from one RCT to another RCT. This may be used if a clinical trial was first conducted in like a high income setting, and maybe there was a follow-up clinical trial that was conducted on the same intervention in sort of like a Rwanda or other regions of interest, and they've transferred the findings as such. And in terms of types of data that you need to conduct these analyses, uh, all of the applications for the source data require individual participant level data, or IPD. And in contrast to, there was no applications of where transporting findings from an aggregate summary level data. And I will just make an important distinction that what we see in like a publications of randomized clinical trial, where the means, the proportions, and different effect population summaries are reported. These are aggregate summary level reporting. This is what we consider the summary level data. And most publications do not have individual patient level data they provide. I mean, you can certainly make data requests, but getting access to timely access to these source data can be very challenging. So we do see this as a potential limitation, and which highlights needs for more methodological development where we can transport the IPD findings or findings used based on an IPD to an aggregate level data, and maybe perhaps there needs to be methodological development to transfer summary level data to either individual patient level data if you have it in the target sample, or if you just have the aggregate level data in the target population as well. And if we take a look at geographically where these methods are being applied, the answer is very simple. It's the US. It's the US. They made up the majority of both the source and the target data sets in which they originated from. And unfortunately, as it stands right now, there has been very limited applications in global health. In fact, we only found 2 studies. One was on HIV, where there's transported the finding from an RCT that was done in US by NIH group to Ethiopia and Thailand, and another study where they transferred the finding from the effects of vitamin A supplementation from 2 provinces of Indonesia to a clinical trial that was conducted in Nepal. I think there is a lot of room for improvements in how we can improve the uptake of these novel methods to improve local decision making. So we will welcome some discussion at the end. But to summarize what's different sort of a value case or different application that have been used could be as such. We could transfer the effects of treatment from that was conducted intervention study in a high income setting to a different population, perhaps in Rwanda. And we can also use transportability analysis to see what are the important effect modifiers for a given intervention. Perhaps this would be modifiable characteristics that we can actually target and be used for delivering the medical intervention itself. And we could also perhaps look at how clinical trials are generally criticized for having strict inclusion and exclusion criteria. So they have is to essentially to have a very high control setting, a highly controlled setting. But perhaps we can use it as a way to transfer the findings to a broader eligibility criteria to those that were ineligible for the participant due to strict inclusion criteria as well. And we can improve the implementation by looking at geographical effects on various medical interventions. And perhaps this could be used to select the most optimal intervention, which I think is highly relevant for global health decision making, given the fact that majority of clinical trial research and other types of research are coming from elsewhere. And perhaps we can use this transfer analysis to plan better clinical trials as we go from more and more exploratory to confirmatory that are trial. We often do need to expand the geographical site. And this may mean that introducing the intervention and studying the intervention in a new geographic location for the first time ever. So perhaps this could be used as a potential way to plan better clinical trials by accounting for different geographic factors in which you will conduct your larger clinical trial. So key takeaways from our landscape analysis is that it's being underused in global health. And I think I've said this multiple times, so I won't go into much detail, and I'll save that for the discussion. And there has been limited applications to aggregate level data. As I noticed before, getting timely access to individual patient level data, whether it's from a publication or whether it's from a real world data source from a government organization, can be quite challenging. But what we do have to note trade-offs, because in having access to the individual patient level data on IPD will likely lead to greater precision. So transferring the findings based on aggregate level data will likely result in more biased results. But perhaps this is something that we can still use. So more work is definitely needed to make these methods accessible. And that's exactly what we're doing at CCS, is that we are actually developing an internal R package for open source R package called that we're calling Transport Help, that currently has the IOPW methods involved. And we will be developing other types of methods that can handle like some of the data privacy limitations, like sometimes due to data privacy limitations that it's not possible to merge both the source and the target data together. That's often the case, and we'll be developing some methods where we can handle aggregate data and how we can transfer that in various settings. Just to conclude sort of the oral part of our workshop is that I'll just present the intended takeaways I presented at the beginning of the talk. We're not undermining the importance of running high quality randomized clinical trials. What we're just saying is that currently they're being done outside of LMICs. The trial evidence is largely coming from high-income countries. So because even though they can ensure high internal validity, we just have to question the local context and consider the local external validity as well. And instead of just qualitatively questioning the lack of external validity, perhaps we can use these novel quantitative methods to quantitatively assess how externally valid the findings are. And this is what essentially what we're saying is the following. In reality, the clinical guideline evidence and clinical guidelines that are basically done on meta-analysis of published randomized clinical trials are not adequately considering the local context. And what we're saying with transportability and generalizability analysis is to consider the local context better in a quantitative manner with using these novel causal inference methods. And just to conclude our discussion or the oral part of the discussion, these are being underused and in global health. And I think that in my honest opinion, there are a lot of room for improvements in terms of both methodological development and also in applications. And we can use as a tool to achieve more equitable healthcare and better decision making for global health. So I will now take some questions and maybe ask the Rutan or others from AQS or the members in attendance whether are there any questions that we can help answer and clarify on areas for lack of clarity.
Jay and Kwang, first of all, thank you very much for the amazing presentation. We've learned a lot. So this is a group of which is made of 90% of healthcare providers. So they have access to the data. Most of them will be aggregated. At the end of this fellowship, we're expecting them to work on their own, come up with doing their own analysis, write abstract at the very least, manuscript for those who can. So hopefully I'm crossing my fingers. I hope one or two or even more will use this this transportability to again go and work on it. I can't thank you enough for thinking of developing an R package for this. And there's a lot, as you said, there's a lot of application of it in Rwanda, but also Sub-Saharan Africa, in Sub-Saharan Africa. So they usually have a lot of great questions. So the floor is yours, guys. Ask away, ask in Kinyarwanda, ask in anyway, I'll translate. So, me personally, I've learned a lot, and just maybe we can do it offline, but if you don't mind, I'd like you to maybe if you have time to redo this for the university, and for our master student for MPH, MSc, AP student, because this will have a lot of application that I can foresee. Thanks, thank you very much, Jay. Hello, fellows. Please go ahead and ask some questions. And again, I've worked with Jay. He's super generous and amazing mentor. So ask questions, so it gives you an opportunity to work on some project with him and use the transportability method. Maybe while we are waiting, Jay, my connection was...
Rutan, there are some hands up. Like, can you see the
yes,
attendees?
please.
Okay.
Let me.
Genevieve?
Oh yes, this Obed. Yes, Obed, we can make you a speaker. I was expecting Javier and Obey to ask questions. They're usually very there. Oh, we have more, even Alice. Thank you. Thank you, guys. Thank you for asking. Let me just go. I usually was able to do it.
Maybe you guys can ask in the chat. It might be easier.
Can you try to ask in the chat, guys? I was able to do it last time. Wanisha ngamagara Louis.
Okay, I think there's one question. It's from Emmanuel about how can transportability analysis be used to optimize the distribution of goods within a region with varying terrain, infrastructure, and population density. Ah, yes, that's a good question. Maybe Quang, I will go first and you can maybe add to that after. So yes, so we've seen so these sort of varying terrain, infrastructure, and population densities are sort of these the characteristics of like a geographic regions. Like we know, I've been to Rwanda, and while I spent most of my time in Kigali, we know that uh, the living conditions in Kigali is vastly different from elsewhere. So perhaps we could the analysis does become more complicated, I think, because we're now concerned with transferring sort of the findings to different clusters or geographic sectors, essentially. Uh, it is possible to adjust for different sort of like effect modifiers that may be like a terrain, if there's like a proxy of the terrain that can be measured, and like infrastructure maybe also rated as well, and the population density could be use it as a continuous or some sort of like an ordinal variable, I guess. So no easy answer. I think it's the interesting analytical problem, but perhaps we can, if there are modifiable effect modifiers, and we can perhaps use them to see how well the findings, how well a given intervention will work in different geographic sectors with different characteristics. Quang, did you have anything to add there?
No, not really. That's a great answer, Jay.
Okay. And so I think maybe we will answer the questions I think if you're able to just speak. I apologize. I'm not sure who raised their hands first, but I'm just going to go in alphabetical order. Alice, maybe we'll start with you.
Do you hear me?
Oh, yeah.
Okay, thank you for the presentation. Some questions that I need to ask. The first one is, what's the difference between the effect modifier and confounding factors? Second question is, what's the difference between transportability and generalizability analysis and meta-analysis? And third question is, what is the criteria that we need to focus on when you are doing these transportability and generalizability analysis in order to use the findings from the other countries when you want to use those findings in the local region? Thank you.
Sure. Quang, did you want to start with the effect modifiers and confounders first, maybe?
Yeah. So, confounding covariates, they are more technically, they cause the treatment and the outcome to change at the same time, rather in addition to the treatment changing the outcome. So when you just measure the association between the treatment and the outcome, the association is distorted by variations in that confounding covariate. Covariates which cause confounding don't necessarily change the direct effect that the treatment has on the outcome. For variables that do change the effect of the treatment on the outcome, we call them effect modifiers. So if there were a medicine that was more effective among female patients than male patients, then sex would be an effect modifier for the effect of that medicine on the corresponding clinical outcome. Now vice versa, effect modifiers don't have to be confounders, like they don't have to affect the outcome in treatment at the same time. So yeah, they are a little bit different, but some variables can both be covariates and effect modifiers. So the distinction is just their relationship to the treatment and the outcome. Yeah.
And I think the second question was about transportability analysis versus generalizability analysis and meta-analysis. So maybe I'll start with an easy one. The meta-analysis just refers to analysis of multiple studies. So like a WHO, for example, does a meta-analysis of published randomized clinical trials where you're essentially pooling the different RCTs together to produce a single treatment comparative effectiveness estimate. So that's what I consider, that's what's a meta-analysis. So transportability analysis and generalizability analysis are different in that they both account for the differences in the distribution of effect modifiers between the source data and the target data that we have. So transportability analysis is essentially when we try to transfer the finding from, like US to Rwanda, because it's a different setting. But generalizability analysis is which, if, for example, they did a clinical trial in US, and essentially what we do with these various studies, including RCTs, is that we take a sample of participants from the population themselves, right? And if we are to figure out the external validity of the RCT finding to the broader US population, that is the application of generalizability analysis. So it's just that generalizability analysis is a special case of transportability analysis in that, but it ultimately comes down to where does the source data come from and what is your target population of interest. They're quite related, and we will admit that the terminology doesn't get quite, there is inconsistent sort of terminology used in the field. And I can't remember your third question, but we will maybe move on.
My third question was like, what the factors do we consider when we are doing transportability and generalizability analysis? For example, you heard about maybe use of iodine salt in USA, and then you need to apply that study in Rwanda. So when you are doing generalizability analysis and transportability analysis, what are the factors do we consider here in order to analyze that studies?
Sure. I will just highlight that we use the US and Rwanda as a sort of like a hypothetical case study. There may be some, it's like other practical factors where like conducting these analysis may not be like a valid. So I guess, I think we would probably need to consider what types of data source you can get access to. That's first, right? And I think when we come up with sort of like the research question and we collaborate with stakeholders to sort of figure out what are the sort of the causal relationship between the treatment and the outcome, and also study participation, that's an additional factor that we need to consider in transportative analysis. It may be that sort of a lot of the covariates or confounders, and as well as the effect modifiers, may not be measured. So we may need to consider whether they're measured or not, because you can't do the analysis on variables that are not measured, that are not in your data set. As well, you may need to consider the quality of the data. In sort of a lot of the observational data and real world data sets, there can be a lot of missing data. So those like practical aspects you need to be considered when pulling out these when conducting these analyses. And again, we are not saying that you should do transportability and generalizability analysis for every question out there. It's just that we're just proposing and trying to increase the awareness, this as a methodological tool in which we can assess the external validity by taking into account for the local context.
Okay, thank you. I
Uh,
have another question,
sure.
if you still have time. So how do we maximize this kind of validity, internal and external? How do we maximize both?
So, I think running like maximizing high internal validity or the controlling for confounding is perhaps easier because you can run high quality randomized clinical trials. And you may be able to do propensity score weighting approach or matching approaches to adjust for confounding within sort of the original study source data itself. But I will admit that randomization, does achieve high internal validity the best. And you may have some model misclassification, and due to sort of the data elements challenge that I mentioned before, that you may actually not be able to control for all the existing confounders in your model. And there may be also some sample size limitations in which you may not be able to adjust all of the covariates that and confounders that you have. In terms of maximize external validity, from an experimental design perspective, we can do that by running pragmatic trials in the local setting. So I've been an advocate for running better and more clinical trials in LMICs for global health for most of my career. But what we're saying is with these causal inference method is that these are sort of maybe perhaps a short-term solution that we can use to as a practical solution to mitigate the fact that we don't have many clinical trials and other high-quality observational studies being conducted in LMICs. I think for the respect to other audience, I will move on. I think Alice, you had your hands up next. Okay, if Alice is not on the line, maybe Marth. I apologize if I'm not pronouncing your names correctly. If not, then maybe John Cloud. What? Okay. Maybe I'll move up to the next, like sort of the typed question in the chat. I think there's given Rwanda's unique socio-cultural context and rapid development, how can generalizability studies be conducted to ensure that research findings from international studies remain ethical and relevant to Rwanda population? I mean, I guess the alternative of not doing adopting this causal inference analysis is just you read a paper from these international studies and you just judge subjectively how applicable these findings are in the local context. That's totally fine. It's just that we're just providing this as a tool where we can quantitatively assess how valid the international study findings are to the local setting, and perhaps these sort of the unique socio-cultural context and other geographic factors. If they are measured, then we can maybe control for them and or the differences between them and the setting in which the international studies were conducted. Okay. And okay, so good question. Why do you think RCTs are not conducted in low-income countries? while is the biggest market. I mean, I think biggest market is the US. There whereas the largest sort of the pharmaceutical activities does occur. I think maybe it's perhaps due to lack of familiarity, and maybe it's perhaps not an infrastructure challenges that may exist and largely funding challenges that exist in this region. I believe there are a lot of important initiatives going on to increase sort of the sort of like a clinical trial activities in Rwanda specifically. And I think South Africa is a great example. There are a lot of clinical trials being conducted there, including those that are sponsored by pharmaceutical industry. Is there? I don't think there's a one right answer I can give. And apart from comorbidities, do you believe race can be one of the effect modifiers? Yeah, I mean, I think depends on sort of the mechanism of actions of the treatment being studied, but sure, I think race can definitely be an effect modifier from both biologically and from a social context. And the last question was, despite underuse currently, has it had an occasion to be presented to WHO for further endorsement or scale up? Yeah, great question. We haven't done that ourselves yet, but I think we'll definitely look to present more of these at important stakeholders like WHO and elsewhere. I think we do have a lot of room, mountain to climb, because I think large organizations like that will be stuck in their own ways, um, and sort of the current practice of evidence-based medicine does prioritize internal validity a lot more than external validity, and so the emphasis on confounding is a much greater, or relative place importance on that is much greater for these global stakeholders. Yes, I think there's one question about how to understand confounders or control using propensity score matching and propensity score weighting. Quang, did you want to maybe answer that?
Yes, sure. So the actual mathematical reason is too complicated to go for this session, but generally, the effect of propensity score matching and propensity score weighting is that it makes the distribution of confounders more similar between the treatment and the control group. So in a sense, in an informal sense, we can say that, okay, we made the confounders the confounders are roughly the same between the treatment and the control group. So any difference between them has to be due to the difference in treatment. That's not and the entire story. Like you can mathematically prove that given some causal inference assumptions, the propensity score methods give you unbiased treatment effect estimates. But that's generally how I like to think of it informally.
I think there was another question about propensity, which I believe it was answered. There was one other question I would ask, while we need to look about intervention, the case and control might be an equal number. It's just to answer that, I'm not sure I fully understand the question, but sort of the number of patients that are in the intervention control group doesn't have to be equal. In a randomized clinical trial setting, we tend to use like an equal allocation where we have a 50-50 split between the treatment and the control, because all else equal, this can maximize statistical power in a clinical trial that's studying a two-arm clinical trial. Okay, and my question fall to, what is the difference between internal and external bias? So internal bias largely has to do with confounding, and how well you can control for the different confounding. And as I suggested, by the use of randomization, randomized clinical trial evidence. So randomized clinical trials can yield high internal validity, high findings with high internal validity because they're able to control for, or they're on average create study groups that are comparable in both the measure and unmeasured prognostic factor. And this is due to the fact that we randomly assign participants to either the treatment or the control, and so we remove selection bias. So on average, we can achieve comparable groups, and therefore we can achieve high internal validity, and where we have low internal bias, essentially. And external bias is essentially randomized clinical trials may not adequately do that because due to the fact that, for example, the clinical trial may be done elsewhere outside of the region in which the local decision makers are trying to make a decision on. I think it's fair enough or safe to say that most government or other local decision makers would like to see the findings come from the population in which they're treating or they're making the policies based on, but we know that's not really the case in current reality. And I think regarding the source data and the target data, just simply referring to where was the original study conducted from, where that's coming, that's referring to source data, and the target data is, for example, like where is the data in which we're trying to transfer the findings. So, for example, in the case study that we illustrated, we used an observational study that was conducted in the US. The data from US would represent the source data, and the data on effect modifiers and etc. from Rwanda, because we're trying to transfer the findings from US to Rwanda, that would represent the target data. Hope that's clear. And one more question: what are the possible solutions for African researchers such that they can conduct clinical trial that are? Oh yeah, I mean, no right answer. I mean, I think from because we are methodologists, we tend to focus on like capacity building and making these sort of like analytical tools more accessible. I think there could be more funding opportunities to improve, training of like sort of like human capital or human capacity to be able to do more clinical trials in these regions. As well, I think there needs to be some work to attract more maybe for like a pharmaceutical interest to conduct clinical trials in the regions. I don't think there are one or few easy solutions. I think it will take some time to change, but I think we can get there. Rutan, I think we have answered all the questions. Maybe we'll just conclude the session then.
Yeah, thanks, Jay. Thank you very much for yeah, we can conclude the session. Usually this session for us take 1 hour. I'm really amazed by the interest. I mean, we might have to come back to you, and hopefully we'll have the opportunity to have 1 or 2 students who are interested in doing this. Kwang, really nice meeting you. And if there's any way you need some random data to test your package, feel free to reach out. We have a team of data scientists that will love to participate in this. There's a lot of maybe the last questions that we can go on offline with Jay. Why is transportability more popular? Is it because I think in terms of economy, in terms of speeding up the use of evidence, this should be the way to go. What should we do? How can we help in this mission of making sure that this is way more mainstream than it is now? But
Yeah,
maybe,
I mean,
yeah.
good question. I think it's for many reasons, like causal inference doesn't get taught well in most university. I will say that I don't know if there's a course on causal inference at my own institution, McMaster. And I think transportability analysis and generalizability analysis are, relatively new, and they've been sort of focused on these sort of like large US academic institutions like Johns Hopkins and so forth, where they have a very strong, like profs with causal inference interests. That may be one of the reasons why we've seen more applications in the US. But yeah, I think, yeah, happy to talk offline about how we can sort of increase the awareness and increase the adoption in situations where there are a good fit. But thanks
Thank you,
for
Jay. Thank
having
you
us.
very.
Thanks for
Yeah,
having us.
thank you
And yeah,
very.
it's great,
Yeah,
great
yeah,
questions.
yeah.
Yeah, thanks so much.
Thank you,
And
Jay.
we'll
So
share
if
the
I can just,
slides shortly.
yeah, yep, yep. Thank you very much. So even if you are amenable, we can organize something similar for the University of Rwanda and maybe UGHE as well. Because I can't agree more. We need to have we have to play a small role in increasing the awareness of on these two very important concepts. Thank
Okay,
you, Jay.
sounds,
Again, I can't thank you enough. Thank you very much.
yeah, no problem. Thanks for having us. Bye.
Thank you.
Bye.
Bye.
Ah,